Thank you for attending this webinar titled Achieving Efficiency and Accuracy Utilizing Technology in Hip Arthroplasty. I'm your moderator, Dr. William Lutz from Aurora Medical Center, and I have a group of a number of surgeons here, which I will introduce momentarily. But before we first get started, I would like to go over some objectives just from high-level perspective. Tonight, I'd like to have a high-level discussion regarding improving precision and accuracy of component position for total hip arthroplasty. Secondary objectives are going to be, my hope is to pass on that we can do some things differently in the operative suites to improve operative time and improve our efficiency. I hope we can come to a conclusion and a consensus as a group where most of us have had success and give you the opportunity to take that back into your operative suites. Secondarily, how to bring computer-aided navigation into the hospital and more importantly into the surgery centers as we transition to outpatient total joint arthroplasty in a more rigorous fashion. And lastly, to understand current data as it relates to computer-aided navigation. So my surgeon panel today is Dr. Brad Waddell. He trained at the Hospital of Special Surgery, did his orthopedic fellowship training there, and he did his medical school at Louisiana State University Health Sciences Center. I'm proud to have Don Holman from Texas Orthopedic Associates, who did his fellowship at Brigham and Women's Hospital at Harvard Medical School. Paul Sassura is with us, who did his training at the University of California Davis Medical Center. And finally, Scott Nodzo, who is back where he trained at the University of Buffalo after doing his fellowship at the Hospital of Special Surgery. So I'd like to get this started on this discussion and how we can achieve efficiency and accuracy utilizing technology in total hip arthroplasty. So I'm going to keep this quite informal. So let's start with Brad, and I just have a quick question for you. How long have you been using navigation in total hip arthroplasty, and kind of tell us your background with that? Also give us a sense of just kind of how you're using it overall from a high level perspective.
Sure. So I was pretty fortunate to, during my residency, have some early adopters of navigation, robotics, all the different things. And so in my residency at the Oxnard Clinic, somewhere in the realm of 2010, 2011, we were using computer navigated and then transitioned to some of the other navigations. So pretty much all throughout my training, starting at the Oxnard Clinic, moving on to Hospital for Special Surgery, I was introduced to it, which allowed me in my early career to adopt it as well. Of course, I've tried a number of different navigation technologies involving the hip, and so I was very fortunate to have mentors who were early adopters of some of these technologies, allowing me to adopt them early in my career.
Yeah, nice.
And then specifically for OrthAlign, early 2018, I was fortunate to have met some of the engineers at the academy, and then jumped into OrthAlign in early 2018 for the hip application.
Right, absolutely. Do you have any idea, how many, my understanding is that you're using this primarily in most of your primary total hip arthroplasties, or all the time, 100% of the time, or?
So I mostly do anterior hip replacement. So I use it in almost 100% of my anterior hip replacements. There's a few where one thing or another may impede me from using it, but for the most part, I use OrthAlign in every anterior. I've used it in a fair number of my posteriors, but those are few and far between, typically fractures or something along those lines. So I don't utilize it in as many of my posteriors, but there's not very many of those to begin with.
Understand. Excellent. Hey, Don, quick question for you. What stimulated you, what compelled you to start using computer-aided navigation with your total hips, and kind of tell me what you're getting out of it right at the moment?
So for me, advances in technology, which are sort of the way I look at everything that is happening around us, I think that is going to become more and more the standard of care, and more necessary for us all to learn and adopt these techniques, because I think that all of this additional information that can be provided to you, no matter how you obtain that information, is valuable. And so, you know, anytime I've ever tried to outsmart the computer, I'm not that smart. So, you know, for me, it was efficiency, eliminating other people from my workflow. So, you know, when I started in practice, I was relying a lot on fluoroscopy for my anterior hip cases. I'd echo a lot of the same things that were just mentioned by Dr. Waddell. It was challenging, you know, trying to track down your fluoro technician when you're, you know, trying to keep going with the case, trying to be efficient in your operating room, and you're waiting for, you know, somebody, you know, to come in and snap that shot when you have your cup in place, and you're pretty sure it's there, but you're not quite sure, and you want to just know exactly, and you want it to be perfect every single time. And then that guy runs off, or that girl runs off, and then you can't get them back to come and check your positioning when your stem is in place. And each one of these things that adds 10, 15 minutes to your case, it breaks your rhythm. It prolongs your operative time. We're all well aware of the issues that are associated with prolonged timing. And so I was just becoming more and more frustrated with all of these additional people that were involved in my workflow. And so for me, one of the things that was really attractive about this technology was it relied only on me. And it literally took me an additional 30 or 40 seconds, you know, for the entire operative time in order to do what I needed to do to get all of the information that I need. And one of the things that I would point out where I think it is the most valuable is not only the positioning, but I'm a HANA table user. And for me, I operate in a hyper competitive market. And so I could throw a rock out of my front door and I could probably hit 5 or 6 surgeons. And so for me, in order to, you know, essentially survive in my marketplace, I have to work at a few different places. So that means I've got to work with a lot of different people. And for me to have a consistent result, I need to eliminate all these, as many variables as I can. And this has been something that has really helped me eliminate other variables. So I know that I'm going to have positioning, and I'm going to have leg length, and all of that, you know, these are the issues, right, that we all wrestle with performing consistent arthroplasty. And, you know, the HANA table, while I may have a table everywhere that I may go, the HANA table can be powerful, and you can wind up with major differences that you may not be able to appreciate because of some other factor that you can't control. So you may have an x-ray technician who thinks they're helping you by changing some angles or something like that, or they're raising your bed or lowering your bed or something that you're not aware of. And when you're trying to crank things through, you may not notice some of these things. And so in a lot of ways, it's really helped me improve my efficiency, my accuracy, but it's also helped keep me out of trouble.
Sure. Yeah. Excellent statement. Absolutely. I agree with many of the things you said. And my hope is in part kind of two here, we can get into that a little bit more. Paul, do you have any techniques that you can share with us that allowed you to get navigation, hip navigation into the hospital or into the surgery center?
Yeah, I think it can definitely be a challenge in terms of trying to get them on your side. The two different scenarios I look at are both the hospital systems where you have to get administration on your side versus the surgery centers where you're trying to get your surgeon partners on your side. But either way, I think the argument is the same. And I'll just reiterate what Don said about the use of technology. You know, I think that in the future, there's going to be more technology, not less technology. And Academy a couple of years ago, the last time we had an Academy before COVID, you know, there was all kinds of robotic systems that are coming out. And I mean, I was amazed at the level of buzz and excitement for robotic systems, navigation systems. It was just, I'd never seen that much prior. And so I'm a guy that's been using computer navigation since 2004. That's kind of like when it first came out. So I've always thought it was a good idea. You know, if there's technology out there that can help me do my job, you know, I'm gonna embrace it. So I think the way I look at it is I think that technology, computer navigation, specifically robotics, I think those are technologies that can help a good surgeon be a better surgeon. And so, you know, I was definitely one of those quote early adopters. And the beauty is, at least in my community, I have seen other surgeons adopt it. So over the years, there have been more and more surgeons in the community that have been taking on the technology, utilizing it, and championing it as well. So, when you talk to your hospital system or your surgeon partners at the surgery center, it's not a difficult argument to say, well, this is where the standard of practice is going. I strongly believe that in the next 5-10 years, it's going to be, just about everyone using this. It's been slow to adopt, but it's definitely getting there. So making that argument, it's going to help you get the hospital administration or surgeon partners on your side to understand, hey, if we want to remain competitive, if we truly want to give the best care to our patients, then we really should seriously consider adopting these technologies.
Absolutely. One follow-up question. Is it easier to sell hip navigation in a case-by-case basis, or is it easier to sell a product that has a capital expenditure to it?
Yeah, especially when you're talking about the actual cost of bringing in a system. There's no question OrthAlign's got a huge advantage in that aspect. Not having a big capital expenditure is a huge bonus, to both a hospital system and a surgery center. And OrthAlign is ideal for the surgery center based on the cost. There's no capital outlay, but also that it's an open platform system. So if you've got multiple surgeons at your surgery center using different hip systems, you can still bring in OrthAlign and anyone can use it. So that's just a bonus.
I think that's.
And I hate to interrupt. I'm sorry, but this is something that's very near and dear to my heart because the majority of what I do is involved in places that are not only hospital-owned but physician-owned partnerships. And so everything that I do, literally down to the stitch, we have accountability for everything that happens, and true granular visualization and total transparency on the absolute cost of every single decision that is made and the reimbursement on every single decision that is made. And I can tell you, at least the way it works for us, is that this is not something that is a negative for us. So the cost argument, and I'm well aware that everybody's circumstances are different across states, and every system is different. But for us, this is not an added expense for us. It's a net value add across the board. As far as our results, our outcomes, and even from our reimbursement standpoint.
Yeah, I agree with you. Don. We just opened up a surgery center, and when you don't have to involve administration and human resources somehow and contractual negotiations, I think it's a lot easier for the surgeons to make a compelling argument for a case-by-case basis as opposed to something that has a lot of capital outlay. Hey, Scott, you're the only one in this setting that's in a teaching hospital. So give us a sense of how computer-aided navigation on total hip arthroplasty has enhanced your ability to take residents to a different level, and how you teach those residents and fellows.
Yeah, so I get to work with residents and fellows on a daily basis, and you have residents, you have all the way from an intern to a chief and all the way to a fellow, so they all have a very different understanding of anatomy and the positioning of a cup or where a stem goes. So, you start with the basics of showing them, we like to tuck the cup inside the anterior wall. Here's a transverse acetabular ligament. And you go over those basics, but to really show them, what does 40 degrees look like? What does 20 degrees look like? If my cup is here and the computer is telling me this, what does changing at 5 to 10 degrees look like to you? And are you able to do that without some type of advanced technology? And I would say, most people can't change things 3 to 5 degrees, just eyeballing it and through a small incision. So it's great to be able to show a resident, this is what 40 degrees abduction, 25 degrees of inversion looks like. This is what the computer tells you. This is what it looks inside the body. These are your anatomic landmarks, and this is what you need to look for, so that if you don't have technology or the technology fails you in the middle of a case, you have that concrete understanding of, okay, this is in general where my cup needs to be. I know I'm going to be in the ballpark if I don't have advanced technology on my side. And it's nice, it's great in the teaching setting. We preoperatively go over, I get sit to stand, lateral pelvis views, and based on, our understanding of pelvic mobility, where do we actually want the cup to go, or where do we think we want the cup to go? So maybe, each patient has a very unique, cup position, teaching the residents, okay, so this spine doesn't move as well, or this is a stuck sitting or a stuck standing. Where do I want to put this cup, and what does maybe 45-25 look like, or 40-15 look like in the body and with computer navigation, and to show residents that, and from a very concrete standpoint, is very helpful in the teaching setting.
Yeah, absolutely. So it gives you the ability to teach on a specific number.
Yeah.
Based on spinal pelvic motion, which is probably something that all of us really have not done in years, is understanding spinal pelvic mobility. And we're starting to understand that a lot more, but it gives us surgeons the ability to really fine tune a number and hit the bullseye, so to speak, right?
Yep. Yeah. And it's, I as a, chief residents and fellows, I always ask them, where do you want to put this cup? What do you want it to look like, based on this pelvic motion? And then they can put it in, and then you can check it with navigation. Like, is this where you wanted the cup? Does this look appropriate to you? And if we need to change it 5-10 degrees, we move it, and then, check it again. And then that you concretely moved it an appropriate amount, as opposed to just kind of, yeah, I think I moved it. It looks good.
Yeah.
You're looking in a small hole and, more or less guessing. And, I'm imageless, I don't use any x-ray or anything. So it's based off of, my intraoperative landmarks, my computer navigation, the OrthAlign navigation. So it's been
Absolutely
awesome.
Good stuff.
I agree with Scott, and I think you could look at teaching in a different aspect as well, and consider that throughout our whole careers we're learning. And I think we've looked at the studies where experienced surgeons aren't putting it where they think they put it in a significant percentage of the time. And so I think the navigation can continue to help us learn, even though we may not be in an academic institution, from each case. So I think there's another way of looking at that. And one thing I like about OrthAlign is it attaches on a universal basis to whatever tools you're using were it not there, and can teach you that muscle memory. And that's what I really liked about it is I had used previous navigation technologies before jumping in to OrthAlign, which didn't allow me to use the normal tools. And in going back to using those normal tools, I had a tough time sort of going through another learning curve. And I think that technology that augments the tools that we're currently using, and probably for the foreseeable future using, the OrthAlign will allow us to build that muscle memory. So now, without even thinking, I can put my hand where I know OrthAlign is going to tell me it's in the perfect spot. And then I test it with OrthAlign, and it just gives me that reassurance. And then can, as Scott said, fine tune it to one of those positions based on the spinal pelvic, balance to where I know I need to be putting it.
Yeah, that's absolutely 100% valid point, and I agree with you. Reproducibility is key, and the ability to understand pelvic alignment is key. And maybe I should take a step back and just go through with you guys. So, Brad, are you you're supine direct anterior, right?
That's correct. Most of my cases direct anterior.
Okay. Don, are you direct anterior as well, or lateral?
I would say the vast majority of my cases are anterior cases. I do a lot of trauma, and I do a lot of post-traumatic things. And so if I've got I just did a case last week. I was taking nails out and screws out of every place, and, you name it. And so I do that, in the lateral position. I do a posterior hip, but I still apply, advanced technology in that setting. But yeah, the vast majority of my cases are anterior cases.
As am I. What about you, Paul?
Posterior lateral.
Okay, absolutely. And Scott?
Yeah, I kind of do a piriformis sparing direct superior approach. So it's
understand. Absolutely. So, I'm going to direct this one to Brad. Have you found that you're able to kind of optimize concurrent cases, especially a lot of joint guys? We tend to go room to room to room. Do you think that OrthAlign has helped your flow? And if so, how? And then secondarily, does it change your flow intraoperatively when against traditional approaches? In other words, are the steps the same or are they different?
So yeah, I think I'll take question one is how do I maximize caseload? And I have found it to be very easy after switching in 2018 to OrthAlign. Prior to that, I was using a technology or navigation system that was quite expensive. And even when I was practicing at the hospital for special surgery, after my fellowship, there was still a limited number of those technologies. And so in flipping rooms, I would have to choose all of my cases for the day that I would use with that certain technology in one room and then use something else in the other room. Whereas with OrthAlign, because of its low, no capital expense and the ability to have it separately in each room, it's allowed me to sort of go with impunity, scheduling cases in whatever room I want. I think another important point is that, let's say I have a cancellation in the room where my excessive capital expenditure technology is, I may switch something in there, but I'm not able to switch something that wasn't there into there quickly. So what I love about OrthAlign, I can schedule someone the same day and use OrthAlign. It's completely, as Don was saying earlier, 100%. It's just me and what I get inside of the operating room. And so it has allowed me to have a freedom in my schedule that I didn't see with other technologies. So I think that that's a really, and I always tell this to patients, I tell this to folks when I'm talking to them, is I could pack that in my bag, take it to the middle of nowhere, Louisiana, where my dad lives, and I could do a hip replacement on a table totally without thought. So that's one of the just marvelous things about this technology. I think in terms of my flow in the operating room, it hasn't changed very much. I have not fully eliminated X-ray. However, I have seen the similar results as some of those published either by Ed Sue or by Dr. Taki. And I recently presented my results at the Southern Orthopedic Association showing a reduction in fluoroscopy usage almost by half after the first 15 or 20 cases.
Mm-hmm.
I showed accuracy improving immediately. And then most importantly is while my team and myself took a little bit extra time during the first 15 or so cases, there was a significant downward trend only to about 10 minutes longer than standard by the 15th, 16th case. And now it's basically time neutral as I'm in a far greater number of cases.
Yeah, no, that's I have found the exact same thing, and I would second everything you just said with respect to what I've seen in my own practice, and just recently submitted an abstract to AUKUS on my experience of a large number of direct anterior OrthAlign cases, and it's very, very accurate. With we're within just over a millimeter on leg length, and of course we don't get CT data on all of our postoperative patients, but China and Japan do, and they've seen the same type of reliable results. And that really is the gold standard, isn't it? Obtaining a CT scan, but we just can't do that in the United States for cost containment. But this next question, I really want Paul to look at a little bit. Does he have any tips for time improvement in the operative suite, or obtaining economic efficiency? Anything that he's doing different than, say, a traditional method might be?
When I first got into practice, I would get intraoperative AP pelvis, a cross-table AP pelvis X-ray with every case to look at my cut position. I put the final construct, or put the trial construct in, reduced, and check leg lengths, offset, all that kind of stuff. But as I started to utilize navigation more and more, I've eventually realized, well, I've never changed my cup position after getting an intraoperative cross-table AP pelvis film. So I basically stopped getting that. The other thing I stopped doing was putting a trial liner in that cup, trialing putting a trial construct in, and then quote buying it with a final implant. So I've cut that step out entirely. So with the adoption of computer navigation, and that was the old system I was using. Certainly I do the same thing with OrthAlign now. I trust the system so much that, one, I don't need to get an x-ray to confirm anything. And I don't even put a trial liner in my cup anymore. I put a screw in, I put a single screw in all my cups, and I put my liner right in, and then I go from there on the femoral side. So those two things alone cut 20 minutes out of the case. So, every case now is it's less than an hour. It's pretty darn efficient. But there's no question that computer navigation allowed me to make that jump.
Don actually mentioned that earlier. He doesn't have to rely, like I don't have to rely on my radiology tech to not be there while they're out having a cup of coffee or whatever, or on their cell phone and get up to move the machine in and out. And so I found that using OrthAlign has saved me about 17 and a half minutes on average per case, direct anterior case. And you're saying that you maybe 20 plus minutes because you don't have to rely on someone else getting an x-ray, seeing an x-ray, etc.
And
also skipping the trialing.
I'm sorry, I didn't mean to interrupt you. I apologize. I would echo all of those same comments, but I would also say that what this does is this offers you not only the opportunity to eliminate your x-ray reliance, but it also saves you in your other rooms. So we do hip knee. So I do an OrthAlign knee in the other room. Well, that saves me in my tray processing, saves me on the expenditure of all of that, which when you're really looking at the nitty gritty of that, that's hundreds of dollars every single time you're looking at that. We do basically a one tray knee, even if I do an off the shelf knee with, there's no additional instrumentation that you need. This helps you streamline all of that, which saves you on that end, which saves your team, which allows them to be less burdened by the needs of getting your next room set up. Not only does it save you 15, 20 minutes or more during your hip case, but it saves you in your other room while you're getting your other case ready, saves you on your costs of getting all of that ready. So it's not just your time of eliminating your x-ray and you're eliminating your x-ray processor. It's the time in your other case that you also, you see on the other end.
Yeah. You beat me to my next question. So you're not using any fluoroscopy in your cases at all?
We've gotten away from that because as I've done more and more cases and just becoming more and more familiar with the systems that you're using, and everybody that I talk to about that, they say to me, oh, how do you check XYZ? And, just like was just pointed out by Paul, he's not changing it. He's, he knows when it's there. And everybody, once you get to that point, when it's there. So once you trust the technology and you have experience with that and you're confident in your results, you just move forward. And I think, there'd be evidence that would support that too, right? Templated cases, improve your efficiency, where you're going, what you're doing, where you're headed. And you get to that point, you put that in, it's going to be good. Well, all this does is just give you not only where you're going, where you're headed, but it gives you the absolute, like you pointed out, within a millimeter or two of that length. And, you can get your offset, you have everything there that you need. You just move on. And it's been my experience that all I'm doing is I'm just slowing down my process by doing these other checks and balances because I already know it's there.
I got to tell you, I have not. In fact, we just are getting ready to publish on this, but I've gone from about 18 to 20 seconds of OR time when I first started, or C-arm time, sorry, and I'm down to on average about 3 seconds, and it's primarily for fit and fill. What about Brad? Has Brad? Have you stopped?
This is my second time going through this with navigation. My first 2 years, I relied on a single source of navigation, worked my way off of lead as I trusted the technology, and eventually got to wearing no lead, taking about 2 seconds. And That's soon to be published. And now since 2018, I've gone through that permutation with a second set of technology. As I mentioned earlier, I went through a new learning curve, or a relearning curve, because I had not used the normal instrumentation. So I think this learning curve, both with going through the process again, I've been a little more nervous, and I have gotten myself down to about 2 seconds per case. I take an x-ray. Once I get the trial stem in, I don't find the cup to be problematic. I can look through. I use a 3-hole cup in every case. I can look through and I can see that I'm down. So I feel very confident about the cup. It's the stem that gives me pause, as most of the studies show that undersizing can be a problem. And so I think my 2 x-rays that I basically take are once the trial stem is in, and then once the final construct is done. And that seems to, you're nodding, which means you're probably doing the same thing.
I am. Yep.
And I believe that I am on, and again, I don't wear lead any longer. I do the same thing. I sort of stand behind. And I believe that I'm getting to the point where x-ray will be fully eliminated. Just like with, I think training in my residency was only posterior. And again, I never use x-ray in posterior. I can hear, I can feel, I can listen. I was only just introduced to anterior in my fellowship. Loved it, loved seeing what I saw in the clinic, which is why I made the transition. And I think because I'm only in my 5th or 6th year of doing anteriors, I still, and I'm one of the most nervous people you'll ever meet in your life when it comes to patients and taking care of patients and making sure I don't mess up. And so I still am going through the repetitions there, though largely ahead of where I was just 2 years ago.
Well, I think it's interesting to note that this has been published on before, and Ed Su published on it not too awfully long ago in the Journal of Arthroplasty. And what he found when he published on handheld navigation, OrthAlign, is that it really, in his particular instance, it cut 50% off his time using fluoroscopy. I think it's interesting to note that if we can be stewards of the best health of the operative suite we can. What I mean by that is we have a lot of people in that room, including anesthesia, circulating nurses, et cetera, including our eyes, because I don't know too many direct anterior surgeons that use fluoroscopy that use leaded glasses. But I do know that many of us are high volume joint guys, and we have it really down to an art, but many of the moderate direct anterior surgeons are using a minute, 2 minutes, and I've been in some of those ORs. And I think this is something to understand, that using C-arm and having those seconds is not something that it's not something that couldn't cause cataracts or induced cataracts, et cetera. So I think there's some health risks that go along with it. And if we're a little bit better with it, I think we can get this down, like you and I have, to a minimum level, if not get rid of C-arm altogether. And that creates a healthier back and healthier eyes and healthier thyroids, et cetera. So I have to applaud OrthAlign for bringing this technology to market, because it's really changed my practice, and it sounds like it's changed many of your practices as well. And as we get better with this technology, I think we will get better. We'll get significantly improved results. But I think we're going to be healthier in the OR in the long run, for sure. So, maybe I'll pose this next one to Don. Has computer-aided navigation become the standard of care?
Well, I would tell you, for me, I think that, I sort of address these or answer these questions as, well, what would I want to do? I would want somebody to operate on me with every opportunity to make everything as good as it can be. And so, I've seen, and I've been very fortunate to work with people that are masters of their craft, and having watched those people and then trying to ask them, how can I, as your humble, mentee, how can I reproduce what you're doing? And I've heard things from people that are household names. So they've told me things like, well, you need to use your mind's eye. And, I don't have the mind's eye of somebody with 40 years of experience. And, but but I go out every day and I try to take care of people. I need to do the best that I can do, and I need to be able to do what you're doing. And so, you know, I like to think that I'm developing that, you know, sort of gestalt, you know, or whatever you want to call it. And, you know, hopefully someday I'll be able to, you know, teach people that and, you know, show them my mind's eye. But, you know, I think that, like was mentioned earlier, I think Paul said, I think that this kind of thing makes somebody who's capable and somebody who has a reproducible product. I think that this helps make you better. And you know, I don't think anybody can really argue with that. I think that, you know, technology helps you at least some way. More information is always better than less. And relying on your mind's eye is maybe not the most reproducible, you know, best outcome that you can provide for every single one of these people. And you may get by with it. You right, like we all know, like was mentioned previously, you know, you may err on the side of something that actually works in your favor, but we already know that we don't know where we're trying to put the cup. So if you're trying to shoot for something different, how do you even know where that's going? You know, so I think that these things are incredibly valuable. More information is always better than less, and that is my take home, you know, every single time.
Yep.
Yeah, it's so great too when you preoperatively template everybody, and you know, I template, oh, I'm lengthening this person 4 millimeters, and at the end of the case, OrthAlign says you lengthen them 4 millimeters, and then, you know, you can leave that room,
Take that to the bank.
you know, like, this is exactly what we templated, this is exactly what we did, and you know, you have objective measurements where you're not guessing, you know, you lengthened them, but how much did you lengthen them, you know, et cetera, et cetera. And my use of, you know, and OrthAlign has definitely also increased my use of, you know, getting it really dialed down to, oh, I'm using a -2.5 head here, a 0 head here. And I know that walking into the OR based off the template, and then, you know, exactly measuring up, you know, in the OR as well.
So I'll echo what Don was saying, and I'm publishing later this year. It's been presented at AUKUS in the Academy, but I came out of fellowship using navigation, a different navigation, but navigation nonetheless, straight into my practice. And I've presented and soon to publish on my first 30 anterior hip replacements, my first 30 posterior hip replacements, compared my anteriors to a surgeon who had done 10,000 anteriors, compared my posteriors to a surgeon who had done 7,000. I was identical on the anteriors because he has that mind's eye, and I was better in anteversion than the posterior surgeon. In terms of leg length, abduction, anteversion, and I think that this will become the standard of care as we show that it will shorten the learning curve. And I think as surgeons choose the technology, they have to look for the most value in that technology. I have found the value of OrthAlign to be significantly greater because of the cost-quality relationship than the other technologies that I've used, and it's the reason that I'm such a firm believer in it. But there's no question technology will be used. It's going to shorten the learning curve. And while, you know, we're still figuring out exactly where to put it, when we finally put our hand or our needle on the spot where we need to put it, we are going to have the technology available to put it right there.
Absolutely.
I just wanted to add, when I talked about computer navigation to patients and kind of explaining it, you know, I just tell them it's kind of like hanging a picture on your wall at home. I mean, everyone's done that thousands of times. You can hang a picture on your wall. You can look at it, and you know that's center, you know it's level, right? Because you've done it so many times. And we're all high volume surgeons. We're all very good at doing hips, right? Because we've done a ton of them. But if you really want to know, is that picture centered? Is that picture level? You're going to take a tape measure. You're going to take a leveler. So those are tools that help you do that job better. And navigation is a very fancy tool to do just that. You know, so it's a pretty simple explanation that patients get and understand. And I mean, as surgeons, again, yeah, why not? Why wouldn't we use a tool that helps us do our job better?
One quick question. Actually, I'm going to finish up some my last thought here, and then maybe I'll open it up a little bit, and we'll have kind of a free for all. But this one's going to go to Scott. You know, the Rush guys published in 2018 and actually 2019, sorry, they looked at Medicare data, and they looked at over 800,000 total hip replacements. And when they looked with computer-aided navigation on those patients, there was a really strong correlation between lower dislocation rates. And it's really compelling data and I think it's the first study that I know of with this large of data set, over 800,000, that clearly showed that there's a lower dislocation rate and a increased precision rate of getting your abduction and anteversion of the cup positioning perfect. So that, they also found with that, so dislocation rates were lower, also aseptic loosening rates were lower in that particular study. Do you think there's more to it than just the cup position, or do you think that we're just getting better? Because someone, I think it was Don that mentioned, or maybe Brad, but we don't really know where to perfectly put the cup, but at least we know how to precisely place the cup. And when we do know the spinal pelvic orientation, we can put it right where we want it. Wouldn't you say that that's appropriate? But that is compelling evidence, isn't it?
Yeah, it's that's a great paper, and even if you have, even the best surgeons aren't 100% every single time, every single day of the week. Even if you have a 1% to 2% error rate in cup positioning, and you do hundreds and hundreds of hundreds of hip replacements a year, and then in your career, that's a real number that ends up being a real amount of patients that you will have outliers with. And everybody's anatomy is slightly different. You have, the perfect acetabulum with a perfect normal anatomy, and then you have the slightly dysplastics that, they're not truly fully dysplastic, but, that cup looks like it's overhanging a lot more when you put that in. When you're looking in the body, the cup's hanging over, more than, maybe your larger male with a perfect cup. So those are all little things that, cause you to pause and maybe, second guess yourself when you're in there. And that's when the navigation really, is helpful, and just, takes a lot of those outliers out, and, some of the questioning of yourself in the OR, even when you've done thousands of hip replacements, everybody's a little bit differently, and, medicine and surgery ceases to amaze me. And there's always a surprise, even in the very straightforward, routine, normal case that you have. Just getting rid of those outliers and having a tool, so you can hang that picture on the wall every single time. Because I have pictures in my office that are a little bit off, and I didn't, probably could have used something a little better than my eye. So it's compelling data to have that.
Yeah, my opinion is and this isn't everybody's opinion. It happens to be just my opinion. Is that I haven't done a traditional hip replacement, if you will, without navigation in about 8 years. And those of us that trained out at HSS, and there's a couple here, Brad's one of them, but I don't think Dave Mayman has non-navigated anything for 12 or 15 years. Is there? I think this is quickly becoming the standard of care, some sort of navigation, whether it be big box navigation or handheld small box navigation. I certainly think navigations over the next 5 years is probably going to be standard of care, and there's probably not going to be too many indications where we cannot use it. Wouldn't you agree?
I completely agree. It is the state. I use navigation for every single case that I do. Revisions, primaries, I'm using navigation, and I don't see a reason why not to, and it decreases the outliers. Your hip and knee components, or the cuts are right, they're in the right position. It takes that variable out. Almost to a fault, I barely check my cuts anymore in the knee. It's I know they're right. I mean, I've yet to be let down by that. And especially with the OrthAlign, it is so easy to use. I operate at multiple hospitals, and I show up with this little box, and I'm like, here, just turn this 4 times and it's ready to go. And that's all you have to do for navigation. It's so easy for any tech, even if they've never seen it, to set it up in a matter of, a minute. And it's just
the one thing that I would also add for that is I think it helps expand your indications and your comfort level for maybe a case you might look at. I just had a case where, I could tell you a few years ago, I had this, terribly dysplastic, Perthes looking, all sorts of things going on in this hip. And I'm thinking to myself, well, years ago, I never would have done that through the front of the hip because I don't know where I'm going. I don't know what, how am I going to put that socket in there? I don't know what I'm doing. But, now I have this extra tool, which provides me with all of this extra information. And so I don't even hesitate, these things that look, unusual, or, how am I going to do that? Or, now I know I have this crutch in essence, where I know once I get it there, I know where it's going to be. And I have this reliable tool that helps me reproducibly perform this operation, even in these, seemingly kind of, challenging or complicated cases. That, years ago, I would have done that. I would have, done a really extensile exposure and opened it all the way up and looked at everything. And then, kind of wrestled with, well, where am I going to put it now? And, more risk of dislocation, all those sorts of things that I would have, bought as a result of that. I don't shy away from that anymore. I know that I have these intraoperative tools that enable me to tackle these things very reliably, reproducibly, and minimize all of those risks as a result of that.
I'm going to open this up to everybody. Learning curve with HIP-aligned for OrthAlign. How many cases would you? I've heard 5 from I think it was Paul, but maybe it might have been Don. But what do you? I'll open it up for everyone. Maybe everybody can chime in on this. Is it really that easy?
Yeah, it's extremely easy. I'm a lateral based, so I use it in a lateral position. So it is very easy. I mean, putting the diamond pins in, very easy and straightforward. Or registering it. So in the lateral position, you register the pelvic plane, the anterior pelvic plane. It's almost like some people don't even think I'm using navigation. It's so easy to register and set up. It's just getting that anterior pelvic plane being parallel with the floor, and getting that positioning right. And it's one click there, and then registering the leg length of the tack. It's probably 5 to 7 cases before you're super comfortable with it.
Now, so 2 pins in the iliac crest. Direct anterior guys like myself put 2 pins in the iliac crest. I do not put a suture in those. I just use a steri-strip, and a week later, nobody even knows they're there, other than there's a steri-strip there. But I've taken those strips off at a week, and they're healed. Has anybody? Scott, have you found any pelvic morbidity associated with that or anything? I have not.
I've had 0 issues with the pin sites or anything in the pelvis, so no issues.
Absolutely.
Yeah, 0 issues.
What about the other guys? Any issues with pins? And what do you think on a learning curve? Is it really that easy? Question mark.
I'll just add a couple things. So yeah, I've been using navigation systems since 2004. I don't know how many pins I've put in pelvises and tibias for hips and knees, but I've never seen a complication from the pelvic pins. 2 days ago, I did a hip revision where a 20-year-old hip, the head had worn, the poly had worn through the cup, so the cup was destroyed. There's a lot of metallosis in there. When I opened this thing, and this cup was grossly loose, he had so much bone loss. The only thing that could have made it worse if there was a discontinuity. There was that much bone loss. But then, I'm trying to put a cup in this thing, and then, well, where am I going to put this cup? But if you're using OrthAlign, you've got an exact idea of where this cup sits in space. You find bone that you can hook into. You lock it up and you're good.
Yeah.
Yep, I use it on all my revisions as well.
Yeah.
I like to, in the revisions, I'll register where the cup is with the OrthAlign. So I put it in, register where the cup is, what anteversion and abduction was.
Yeah.
And then if I need to adjust it, so if the cup's in a bad position, I know definitely don't put it back there. And if it's in a reasonable position, maybe put it back close to where that is and maybe give it a little more anteversion, or, using like some type of dual mobility or something like that. But yeah, it's great to know where the cup is and what you're putting in after that.
Brad, or anything with the learning curve? You went through it at HSS. I mean, you were already up to speed when you got out, but what are they saying at HSS with respect to learning curves?
Well, I think HSS is a different animal. I think that the learning curve, everyone's touched on the physician learning curve, and I think the learning curve, and I've seen this in a couple of different hospitals that I've been at, is mostly with the team, how to make those 4 simple turns, what to set up, do the batteries go this way, does it turn that way, and that's with any of the navigations. And so I look at the learning curve as when we're having where I put my hand out and the right thing steps into my hand. And so my learning curve, because I'm a perfectionist, OCD crazy person, probably is a little bit longer because I've been using navigation and putting pins in. So I think for the surgeon, it matters how long have you been putting pins in? Is this the first time you've ever tried to put pins in the pelvis? That's a wildly different learning curve than someone who's been training on it or doing it with a different system in a different system. I think, though, probably the most significant learning curve is the one where you just close your eyes and things pop in your hands. And that's probably 10 cases, somewhere in that range. Just like with any new knee system, new hip system, it's going to take a bit for them to learn which parts go where. So I think from the surgeon's perspective, it depends on what you've done. And then we all adopt things a little bit faster or slower. It's somewhere in the 5 to 7 range, like Scott said. And then from your team's perspective, it's just like when you bring in a green set of instruments or an orange set of instruments or a blue set of instruments. Each of those different companies have a little bit different permutation. Your team takes a little time to catch up to it. I think that because OrthAlign is all on your table and is not something else somewhere else, going to do this, then coming back, twist this in there, because it all comes in 1 or 2 trays, it's a little bit faster even for your team.
Yeah, 100%. So I'll tell you what, I think we've made some very good points here. Let's try to wrap this up a little bit. I'm just going to make a couple summary comments. So I've been taking notes as we've been going through this. So HIP-Align by OrthAlign is extremely reliable with respect to the efficiency and effectiveness of where you're putting your acetabular component. That's been shown in a couple studies now to decrease dislocation rates as well as aseptic loosening rates. There is really there is no capital expenditure, so it's a case-by-case basis. Financially, there's no capital expenditure, so relatively inexpensive to get into a surgery center or a hospital setting. It is effective in cutting down radiation or utilizing lead, which in effect seems to be more effective and efficient operative flows, and it seems to be cutting time from OR cases. So I got to tell you, I'm having a lot of trouble seeing too many downsides, but I really love the conversation here, and I may just open it up here to anybody else that wants to bring up a couple points, and then we'll wrap things up.
The one thing that I would just add to that, and I think my anterior hip take home is, I'm a fan of the tables, and I've tried various tables, and I think all of them work really well. But I think the one thing to keep in mind with that for anybody that might be considering, starting an anterior hip practice or if you're going to take a look at your cup with your fluoro or something like that, if you're not going to utilize some sort of technology to help you do that, I think the one thing you've got to acknowledge is that the only time that pelvis is exactly where you know where it is before you start the case. If you don't register those points before you start twisting that leg and having your assistant pull down on one side or somebody pulling on the other side, and you start wrestling all of those things, especially in these large men, you don't know where that's going to be when you do snap that shot. And there's going to be some differences when you try to look at that x-ray, even, if you try to compare it to where you started, they always are going to be different. And so if you don't have some reliable reference to where you started before you do the case, and then when you put those implants in, it's going to be different. I don't care how many x-rays you take or how many minutes you have of x-ray time, that's not going to be reliable and reproducible. You've got to be really careful with that. And I too was fooled with that early on. I had a few cases that I, probably belong on Scott's wall up there where you thought, oh my God, how did I do that? And I thought it looked great at the time. And when they came back, it wasn't absolutely perfect where I wanted it. And it wasn't that, I was doing something crazy. It was that I was fooled by the changes that had taken place intraoperatively. And that's just, something that's hard to control. And people move around when you're operating on them.
Yep, completely agree with that. It's same in the lateral position too.
I'll tell you what, if we use this technology, I think the days of hitting our head and saying, man, I thought it looked, I didn't think it looked like that. I think those days are over. We've all been in residency programs when prior to electronic radiographs, where radiographs that were printed might have fallen down some elevator shafts. So I think those days are probably over, and good riddance. And hopefully some of those radiographs are not mine. I'm sure they are. But anyway, so I'd like to wrap this up. I'd like to say thanks to Brad Waddell, Don Holman, Paul Cesura, Scott Nosdell for helping me out during this great technology talk on total hip arthroplasty. I think we were able to get through all of our objectives. So thanks for being efficient with your time, and thanks for the information. Have a good evening.
Thank you.
Thank you, guys.
Okay.
Thank you.